This is Emergency Medicine Cases EM Quick Hits Podcast, and I'm your host, Dr. Anton Hellman.
EM Cases is brought to you by SHREMI, the Schwartz-Reisman Emergency Medicine Institute. That's a nonprofit organization dedicated to improving EM care through high-quality research and education. The opinions expressed on this podcast are intended for general information and educational purposes only and should not be used to diagnose, treat, or prevent any medical condition, nor should they be used as a substitute for medical advice from a qualified practicing physician. Unless stated otherwise, the opinions expressed by the hosts or guests are made in their individual capacity, not on behalf of the Institute nor Medicine Cases. First, a word from our sponsor, Metricade, the experts in complex physician scheduling since 2012. I've been using Metricade's incredible scheduling system for a decade, and it's been a game changer for me and my colleagues. Shift work comes with its challenges, but Metricade helps minimize the drawbacks by ensuring a fair distribution of shifts while integrating circadian-friendly rhythm recovery time into its methodology. Less sleep deprivation means I can be a better EM doc on shift and still have energy for life outside the hospital. Check out metricade.com/EM cases to make your schedule fair and improve your sleep. Are you ready for a new start or a next step in emergency medicine? Trenton Memorial Hospital in southeastern Ontario is hiring full-time EM physicians to join a supportive team making a real difference, where work is demanding but deeply rewarding. Earning potential is over $600,000 Canadian annually, with incentives up to $75,000 and flexible shifts. They offer relocation, licensing, and immigration support for eligible candidates. It's close proximity to Toronto, Ottawa, New York State, and Vermont, and minutes from wineries, beaches, and outdoor adventures. Visit quintehealth.ca, that's Quinte health.ca, and click on Physician Opportunities. Now, this EM Quick Hits is a special one and a longer one than usual because to kick off our Women in EM Leaders series with Victoria Myers, we have the one and only Judy Tintinalli. It's an amazing half-hour interview at the end of this podcast that I just couldn't make shorter because there was so much great stuff packed into it, and Dr. Tintinalli is a fantastic storyteller. But before we get to Dr. Tintinalli, we've got a superlative lineup with Deb Schoenfeld on Pediatric Torticollis, Swami on stable VTAC, Petro on post-intubation neurocritical care, Morgenstern on how fast or slow we should correct hyponatremia, and Andrew Tagg on managing Paronychia. So let's get into it. And now for the best of University of Toronto emergency medicine. It's my pleasure to have Dr. Debbie Schoenfeld, pediatric EM doc and educator at Hospital for Sick Children in Toronto, as part of our Best of U of T EM series on the show. Welcome, Dr. Schoenfeld.
Thank you so much. It's really nice to be here.
So just tell us a little bit about yourself in terms of your professional career and, why you became interested in education and how you ended up giving such an amazing talk at the Whistler University of Toronto conference this past February.
Well, thanks for the compliment. I'm originally from Montreal, where I did my medical training and then actually did most of my postgraduate training all around the U.S. So I was in New York for a while for residency and then Boston for fellowship for a few years, and then eventually made my way to Sick Kids, where I've been on staff for the last 13 years. I do have a special interest in quality improvement and patient safety. I have a certificate from the University of Toronto in that area, and I spend a lot of my time doing patient safety-related work, including I chair the Pediatric Emergency Medicine Morbidity and Mortality Committee, and have also been very involved with quality improvement teaching in the division and the hospital at large as well.
Fantastic. Well, one of our missions at EM Cases is to improve quality of emergency medicine everywhere. So let's get into this. I understand you have a case from Janus General that is on exactly the topic that we're going to talk about today. So why don't you tell us about that?
Sure. So this case involves a 7-year-old male with trisomy 21 who's brought to the emergency department by his mother. So the story goes he awoke the night prior with what his mother thinks is neck pain. He's got limited verbal skills, but when you ask him, he points to his neck when you ask him where it hurts him. There is no history of fever or any other infectious symptoms, and his mom says there's been no falls or any history of trauma. And on exam, he looks overall pretty well, but he's sitting comfortably, but he's holding his head tilted to the left side.
All right. So it sounds like sort of a torticollis kind of thing?
Yeah, it looks like it.
All right. We've all seen lots of torticollis, and usually it's sort of a benign thing, but as you can probably guess, this isn't going to turn out to be so benign. So far, I'm thinking from the story that it's sort of a classic torticollis, like a strain or spasm of the left sternocleidomastoid. But of course, we need some more information. How about like the ENT and the neuro exam? What did you find on exam?
So his ear, nose, and throat exam is pretty normal. There's no lymphadenopathy. His ears are clear. A rapid strep test is done in the emergency department because there's some question about his throat being a little bit erythematous and maybe that history of throat pain on exam, but it is negative. He resists straightening of his head, but he's otherwise walking around the exam room and well appearing. So he's eventually discharged home, and he's recommended to take some nonsteroidal anti-inflammatories for the discomfort and to follow up with his regular care provider in the coming days.
All right. I feel like that's not the end of the case.
Nope.
So what happened? We had a bounce back?
It is definitely not. So he was brought back to the emergency room 3 days later. His teacher reported to his mother that he started to drag his left foot and he was no longer using his left hand as usual. So he returned to the emergency department. He got a CT of his C-spine, and then neurosurgery took him as a priority 1 to the operating room. He came out in a halo vest for initial stabilization of his C-spine, and then ultimately underwent cervical spine decompression and C1, C2 spinal fusion.
Wow. So I do remember from medical school that there's atlantoaxial instability in kids with Down syndrome, trisomy 21. But I always thought it was after trauma. Okay, we're going to sort this all out. So in this case, I wonder whether just a good neuro screening exam might have picked it up earlier. I suppose that's kind of a key take-home point, that we should be thinking about spinal cord for all torticollis and do a screening history and physical for neuro findings. Is it this atlantoaxial instability that I learned in medical school that trisomy 21 kids have that put this child at risk for this outcome?
So that's exactly it. Patients with trisomy 21 are prone to cervical subluxation due to a combination of risk factors. So hypotonia, ligamentous laxity, and osseous abnormalities, especially of the dens of C2. So although a significant number of patients with trisomy 21 will have radiographic evidence of atlantoaxial instability, only a very small percentage of those will actually be clinically symptomatic. But the majority of those patients will actually be pediatric patients. And the American Academy of Pediatrics actually recommends screening for signs and symptoms or myelopathic signs and symptoms at every health visit. So what does that mean for providers and for parents? And what are the signs that they should be looking out for? So the AAP specifically mentions neck pain or stiffness, head tilt or torticollis, with or without accompanying neurologic changes, such as loss of motor strength or skills, changes in gait or clumsiness, or changes in bowel and bladder control. And if any of these are present, like the patient in our case, further imaging is always required.
Torticollis really is just a sign. It's not a diagnosis. And so there is a differential that we need to think about. And there's a few key ones that are kind of can't miss diagnoses when a child presents with torticollis. Let's go through the differential, and then we'll drill down into each of them to talk about sort of the key features so that we don't miss these things. So what is your kind of can't miss differential for torticollis?
Sure. So I'd say there's 3 main categories, and those categories are as follows. The first is atlantoaxial subluxation that we just discussed, and that refers to a partial dislocation or a malalignment of C1 on C2. Rotary or rotatory subluxation is actually the most common form of cervical subluxation in the pediatric age group. And this occurs when there's a rotational subluxation of C1 on C2. And it can result from osseous or ligamentous abnormalities from either acquired or congenital conditions. The second is acute infections of the head and neck. And probably the most important ones not to miss include retropharyngeal abscess, osteomyelitis, discitis, and Lemierre syndrome. And then finally, the third category would be central nervous system lesions. And that is specifically posterior fossa and cervical spine tumors, up to 20% of which can present with torticollis.
Wait, 20% of spinal cord tumors present with torticollis?
Up to. So the literature, there's different numbers out there, but the literature would suggest that up to 20% can have torticollis as part of the initial presentation.
Wow. I mean, spinal cord tumors in kids, I assume, are pretty rare, but still, that's an impressive number that a fifth of them present with torticollis. All right, so we've got these three groups of diagnoses that we need to think about for pediatric torticollis. We've got atlantoaxial subluxation, we've got acute infections, and we've got CNS lesions. So let's dig into these a little bit deeper so that we can recognize them early. So atlantoaxial subluxation. What are the key clinical features of atlantoaxial subluxation to help us clinch the diagnosis? We know that they present with torticollis, like in this case, and in this case, it was missed on the first visit. Again, would a thorough neurologic exam at first pick this up, or was this just something that you just have to wait until there is something obviously neurologic before you can suspect it?
That's a tricky question because you don't want to start doing C-spine x-rays on every patient who comes to the ER with torticollis. So I would say probably you should be suspecting possible atlantoaxial subluxation when a patient presents with one of three different risk factors. So the first would be a history of trauma. Remember that children sustain ligamentous injuries and subluxation type injuries much more commonly than fractures. And a head tilt or torticollis can be a sign of this. The second would be a history of either a chronic or congenital condition that's associated with hypermobility or spinal instability. So things like trisomy 21, Marfan syndrome, various connective tissue diseases, juvenile arthritis. And then there's a host of more esoteric, rare pediatric syndromes, which are well known to be associated with skeletal abnormalities and cervical spine subluxations, like things like Klippel-Feil and Morquio. Again, a lot rarer, and really only pediatricians would probably be more familiar with those diagnoses. The third category is perhaps the most surprising, and that's a history of recent head and neck surgery. So Grisel syndrome is the name for non-traumatic atlantoaxial rotary subluxation that is associated with inflammatory conditions of the head of the neck and occurs most commonly post-tonsillectomy or adenoidectomy. And it's thought that the local inflammatory process that's associated with pharyngeal surgery exacerbates the already existing ligamentous laxity that we know occurs in children and permits rotational movement of C1 on C2. The last thing I'll add is, although it can be practically hard to appreciate on exam, it really can be helpful to look at the head position in these cases. So in most cases of benign muscular torticollis, the head and the ear tilt towards the side of the spastic sternocleidomastoid muscle, and the chin points to the opposite side. In atlantoaxial rotary subluxation, the head tilts away from the affected sternocleidomastoid muscle, and the sternocleidomastoid muscle on the chin side is where it's tighter and tender, almost as if trying to correct the deformity.
That's a key clinical pearl there. So benign torticollis, it makes sense. The muscle's in spasm, so it's going to be shorter and tight and tender to the side where they're tilting their head. Whereas atlantoaxial instability, it's going to be to the opposite side. So that's a big red flag right there. Just to go back again to review the risk factors. So really the big ones are connective tissue disorders like Marfan. So Marfan's doesn't only cause horribleness in the aorta, but you should think about atlantoaxial instability in Marfan syndrome, trisomy 21, trauma, obviously. And then that interesting one is that I didn't know about is post-ENT surgery, that can put you at risk for atlantoaxial instability due to inflammatory changes. Okay, great. So we've talked about atlantoaxial subluxation, the risk factors for it, when to suspect it, and that key diagnostic feature on physical exam. What imaging do you need to diagnose atlantoaxial subluxation? You had mentioned we're not going to be x-raying everyone. Is x-ray a reasonable first screening test? My understanding is that CT is really what you want, but then there's the radiation concerns depending on age. How do you usually do this?
So definitely I agree. X-rays are a very reasonable first-line radiographic study. So if you're going to do x-rays, the most useful views are the AP open mouth odontoid view and the lateral views. So the odontoid view may show asymmetry of the distances between the odontoid and the lateral masses of C1. And on the lateral view, you want to look at the predental space, which is the space between the anterior arch of C1 and the dens of C2. That's called the atlantodental interval. And in children younger than 8 years old, this interval, or the ADI, should really not be more than 5 millimeters. I will say it's really important to appreciate that x-rays can be normal in these cases, even when there is atlantoaxial subluxation. So in the ER, the definitive diagnosis of atlantoaxial subluxation is made using the gold standard, which, as you mentioned, is CT. And a CT should really be done in all cases where there is high risk or a high suspicion, like that first case of our patient with trisomy 21 who presented with torticollis.
Okay, so CTs are gold standard. We might use X-ray in the patient who's lower risk just as a screening. And again, the key clinical pearl is that the head tilts away from the sternocleidomastoid. Next in the differential diagnosis of pediatric torticollis, as you mentioned, is acute infection like retropharyngeal abscess, osteomyelitis, discitis, and Lemierre's syndrome. Could you just first remind us what's Lemierre's syndrome again?
Sure. So Lemierre's syndrome refers to a septic thrombophlebitis of the internal jugular vein. So the condition typically follows an oropharyngeal infection, and it involves inflammation within the wall of the internal jugular vein, and then results often in bacteremia and septic emboli. And patients are typically febrile and acutely unwell with this condition. They can have tenderness, swelling, or induration overlying the jugular vein or along the ipsilateral sternocleidomastoid muscle, and this irritation can cause torticollis in those cases.
So can you just go over when you'd actually suspect Lemierre's? Because that sounds like a really tough diagnosis to make.
So first of all, it's uncommon. I've never actually seen it personally, but we sort of learn about it all the time. It probably is not as tricky of a diagnosis as you would think, because it typically presents with a patient who looks septic or unwell, but with the combination of findings over the internal jugular vein. So whether that be tenderness or pain, really localized to that area.
Okay, and that's very different than retropharyngeal abscess, which is generally more midline, and also very different to osteomyelitis and discitis, which is going to be also more midline and in the back of the neck. So could you just go over for us some of those key findings, especially of retropharyngeal abscess, because that can be a tough one as well to diagnose. And that's probably more common, I would think, than discitis and osteomyelitis.
Sure. So I think it is worth noting that acute infections with compensatory muscle spasm or referred pain are actually the second most common cause of acquired torticollis in children. But some of the most common infections associated with torticollis are very benign. So this is things like viral pharyngitis, strep pharyngitis, viral upper respiratory infections, and sometimes even like cervical adenitis, which can be treated with short courses of antibiotics. But as you mentioned, there are other diagnoses really that you don't want to miss, because it's really obviously not a big deal if you miss an upper respiratory infection that's going to resolve on its own anyways. So retropharyngeal abscesses is one of the more common shouldn't miss diagnoses that falls into this category. So it occurs most commonly in children between the ages of 2 and 4 years old. And an unwillingness to move the neck because of discomfort is really a prominent presenting feature. So limitation specifically of neck extension is particularly suggestive of retropharyngeal abscess. And some additional signs and symptoms that can clue you into the diagnosis include fever, dysphagia, odynophagia, drooling, and pretty rarely respiratory symptoms like stridor or tachypnea. And a lateral neck x-ray can be very useful in these cases because it can tip you off to the diagnosis if it shows increased or thickened prevertebral space. Osteomyelitis and discitis are really rare diagnoses, as you mentioned. And the point here is just to make sure that you do an exam assessing for point tenderness over the cervical vertebrae to assess for possible infections in these areas.
All right, great. I just want to highlight that. So the So the kitty with retropharyngeal abscess is going to be resistant to movement of the neck, especially flexion extension, just like in meningitis. So anytime you might be thinking about meningitis in a kitty, you should also be thinking about retropharyngeal abscess. All right. So that's a bit about the infectious stuff. There's Lemierre's, there's osteomyelitis and discitis, and there's retropharyngeal abscess. And also just to remember that there's a lot of common, more benign infectious causes of torticollis as well, but those are really the can't miss ones. Our third category in the differential diagnosis of pediatric torticollis can't miss diagnoses after atlantoaxial subluxation and acute infection is posterior fossa and cervical spine tumors, so CNS lesions. Thankfully, these are relatively rare, but again, these are can't miss diagnoses that we at least need to think about in the kitty with torticollis. What do we need to know about CNS lesions as a cause for torticollis in kids?
So I will correct you and say that actually, unfortunately, malignant brain tumors are not rare in pediatrics. And in fact, many people don't realize they're the most common pediatric solid organ tumor. And they are now the leading cause of death from childhood cancer, surpassing leukemia. So that's important to recognize. At least 50% of brain tumors will actually be located in the posterior cranial fossa, which contains the cerebellum and the brainstem and a lot of the cranial nerves. And these tumors are notoriously known to cause torticollis. And as we mentioned earlier, up to 20% of posterior fossa tumors will present with torticollis. And in many cases, this torticollis will actually precede other more obvious neurologic signs and symptoms. Unfortunately, torticollis is underestimated as a symptom of a pathology in the posterior cranial cavity and cervical spinal cord. So while headaches, vomiting, lethargy, and seizures are the most common and obvious symptoms associated with CNS tumors, torticollis and ataxia are common symptoms in those patients with a significantly delayed diagnosis of central nervous system tumor. So tumors in this vicinity, if you're wondering sort of why they cause torticollis, I can sort of share some of the leading theories about why this happens.
Yeah, sure. Because, you'd think that if there's a tumor in the cerebellum, why would they be tilting their head sideways? That's an interesting question.
So there are several theories for this, and I'll share some of the leading ones. So the first is that tumors that are pressing on certain cranial nerves, specifically cranial nerves 4 or 6, which are responsible for extraocular movements, can cause ocular misalignment or double vision. And the torticollis posture can actually be a compensation for oculomotor deficits. So children may actually adopt a head tilt to suppress diplopia or maintain binocular vision. The second is that we know tumors can obstruct CSF flow and cause hydrocephalus, and this can lead to anything from irritability to poor head control, and sometimes a subtle tilted posture is a sign of discomfort or CNS compromise. And then finally, tumor-related mass effect on the brainstem or the upper cervical cord or even on the spinal accessory nerve that controls neck movements can cause painful torticollis. I think it's worth noting, though, that if, torticollis is a result of one of those first couple of mechanisms that I mentioned, so whether it's compensation for ocular alignment or a position of comfort in patients with hydrocephalus, there's often no significant pain in the neck muscles themselves. And children may actually exhibit normal passive range of motion when you try and move their neck. So it's important that the provider not be falsely reassured by a lack of pain. And it's also crucial to perform a complete neurologic exam and specifically keep an eye out for other neurologic signs and symptoms in these cases. So things like headache, vomiting, gait changes, ataxia, and focal neurologic deficits, including cranial nerve deficits.
So the keys here are painless torticollis, think CNS lesion, ask about all the posterior fossa neurosymptoms, and do a cranial nerve exam. And that CNS tumors are not so rare in kids. That's something I learned that's new, with up to 20% presenting with torticollis. Excellent. All right, we've covered the can't miss diagnoses of torticollis. So much was new to me. I hope it's new to the listeners. Any other words of wisdom to leave us with when it comes to pediatric torticollis?
Yeah, I think that, despite all of this talk about the can't miss diagnoses, the most common cause of acquired torticollis is still uncomplicated muscular injury or inflammation to the sternocleidomastoid or trapezius muscle. That being said, acquired torticollis lasting more than a week or not responsive to the usual supportive care measures is not consistent with uncomplicated muscular torticollis and often suggests an underlying structural or infectious etiology.
Okay, great. More than a week of torticollis, you need to investigate and figure out what's going on. Excellent. All right. So just to summarize, remember that torticollis is not a diagnosis. It's a symptom with a wide spectrum of etiologies. Think about atlantoaxial subluxation and trauma and trisomy 21 and Marfan's and post-ENT surgery. If the head is tilted away from the side of the pain, that's a red flag for an alternate, possibly deadly diagnosis. Ask about ENT symptoms and think about retropharyngeal abscess in torticollis and ask about infectious symptoms. Painless torticollis is a CNS lesion until proven otherwise. Benign SCM muscle spasm generally resolves within a week, so acquired torticollis lasting more than a week requires further evaluation. Thanks so much for being on the show, Dr. Schoenfeld. I really hope that we can have you back for more pediatric EM goodies.
I'll be here.
And now a word from our sponsor, Echo. Recently, an EM resident I was working with presented a case to me on shift of a man with a fever of unknown source. And as we were going through the differential, they astutely mentioned endocarditis. So I asked them if they heard a murmur. They said it was so loud in the ED that they couldn't hear a thing. So we went to see the patient together, and I used my Echo stethoscope, which not only made it super easy to hear the mitral regurgitation murmur that clinched the diagnosis, but it helped teach about the murmur to my resident with its enhanced audio and visuals. That was just one time my Echo stethoscope was super helpful on shift. Echo combines the stethoscope you already know with enhanced audio and advanced AI to help you detect heart and lung conditions earlier and with more confidence. Hear with precision, even in noisy environments. Echo's digital stethoscope amplifies heart and lung sounds up to 40 times, and noise cancellation cuts out distractions. Detect disease earlier. Unlock murmur and AFib detection powered by Echo AI, along with sound recording, sharing, and more for early diagnosis and seamless collaboration. Improve diagnostic accuracy. Backed by 4 million heart sounds and 8 FDA clearances for devices and AI algorithms, those who use Echo are 2 times more likely to detect heart disease. I don't have to second guess myself anymore. If you want to pick up subtle heart and lung findings early, I encourage you to join 600,000 healthcare professionals already using Echo. I trust Echo so much that I worked with their team to create a special offer for our listeners. Right now, you can get $50 off plus a free customizable chest piece cover at echohealth.com/EMC. Your purchase is HSA and FSA eligible and may qualify for CME reimbursement. Plus, Echo guarantees you'll detect heart and lung conditions more confidently. If you don't, return it for a full refund. Go to echohealth.com/EMC for $50 off plus a free chest piece cover. That's ekohealth.com/EMC.
A couple of weeks back, our team got a pre-notification about a 55-year-old man coming in with a wide complex tachydysrhythmia. The field vitals were a heart rate of around 160 beats per minute, BP 100 on 52, SAT was 97%. Our EMS team also told us that the patient had a history of coronary artery disease, a couple of stents in the past, and they sent us an ECG, which was a little bit difficult to interpret because it was obtained in the back of a moving ambulance, but it showed a wide, complex, regular tachydysrhythmia. When the patient arrived in our emergency department, vital signs were basically the same. We repeated the ECG now the patient was still, and what we saw was a regular, wide, fast rhythm. Regular, wide, and fast has a pretty short differential. It's ventricular tachycardia, ventricular tachycardia, ventricular tachycardia, and every once in a while it could be SVT with aberrancy, something like a left bundle or a right bundle branch block. But ventricular tachycardia is the thing that we need to have at the top of our differential, and it really should fill the first 3 or 4 spots of our considerations. If the patient's rhythm was wide, fast, and regular, and the patient was unstable, they had some marker of hypoperfusion, hypotension, everybody would move directly to electrical cardioversion. But I often see a lot of hesitancy when the patient is stable. There's more consideration in that circumstance for that SVT with aberrancy, but this really isn't the best way to approach this. There are numerous algorithms that are out there that are designed to try to distinguish between ventricular tachycardia and SVT with aberrancy, but they all fall short. None of them are better than about 80% accurate. What we really want here is 100% accuracy, and all of the algorithms fall far below that threshold. In addition to that, they take time. That's time that the patient doesn't have. They may be stable in front of you now, but the natural course for stable ventricular tachycardia is degradation to unstable ventricular tachycardia and degradation to death. Time is not the friend of the patient or of the clinician. And so what we want is a 100% effective approach to taking care of this patient. And the way to do that is to assume that every time you see regular, wide, and fast, it's ventricular tachycardia. One thing I'll insert there for consideration is that if the rate is below 110 beats per minute and the rhythm is wide and regular, you should consider hyperkalemia, but the hyperkalemia rate is usually going to be far below the ventricular tachycardia rate. If we take every patient who is fast, wide, and regular and above that 120, 130 beat per minute threshold and treat it as ventricular tachycardia, we're going to win. If we're right in the diagnosis and we treat it as ventricular tachycardia, we win and the patient wins. If we're wrong in our diagnosis and we treat it like ventricular tachycardia, we still win. The things that we're going to do to convert ventricular tachycardia will still work to convert SVT with aberrancy. On the other hand, if you guess SVT with aberrancy and you're wrong, there's a significant chance of progression of that ventricular tachycardia and the patient can decompensate. Fast, regular, and wide, think ventricular tachycardia every time. And in our case, this patient had other factors going towards ventricular tachycardia. Based on age and the history of coronary artery disease, it was far more likely that this patient was going to have ventricular tachycardia and not SVT with aberrancy. Once you accept the diagnosis, don't try to use any of the algorithms. You've got to move to treatment. And the bottom line is that we should be going with electricity in all of these patients. It's true that ACLS allows us to consider chemical cardioversion in patients with stable ventricular tachycardia, but the meds really aren't that good in terms of efficacy. The ProCameo study from 2017 showed that procainamide was clearly far better than amiodarone for chemical cardioversion, but the rate of conversion for procainamide was far lower than we would like to see. It was only 67%. For amio, it was only 38%. So under best circumstances, using procainamide, you're only going to convert 2/3 of patients. That's far too low because not only do I want a 100% effective approach to taking care of the patient, I want a treatment that is going to be 100% efficacious. And that treatment is electricity. If you want something that is going to convert the patient just about every time, it's electrical cardioversion. And not only is electrical cardioversion more effective, it's also safer. When we compare side effects of electricity versus these medications, electricity is the clear winner. If the patient's awake, of course, you can give them a little bit of sedation. Etomidate is my go-to here, but you could use propofol as well. And then once you get that patient sedated, light them up 200 joules on your biphasic device. There's a common phrase in the US when it comes to ventricular tachycardia, go with Edison, not medicine.
That, of course, was Anand Swaminathan. Thanks so much, Swami. Love that. When it comes to VTAC, go with Edison, not medicine. That's classic. Next up, we have Andrew Petrosoniak, our go-to traumatologist, who's going to talk about post-intubation neurocritical care. You know, once you've got that tube in, it's not just high fives and pick up another chart. There's a lot more work to do. Take it away, Petro.
Imagine the scenario, a 45-year-old male who's fallen down a flight of stairs. It's clear he has a severe head injury. He's exhibiting posturing in the ED. You move forward with intubation, which is uneventful. But now what? I think many of us feel like the intubation is the most important part. Well, it's actually just the beginning. It's no doubt important, but the care afterwards is equally, if not even more important. So let's talk about what that looks like. and how we can extend the amazing care we delivered during the intubation until the time this patient transitions to the care of the ICU or neurosurgical team. We've touched on ICP management with medication before, so that won't be the focus here, nor am I going to discuss the specific hemodynamic targets for these patients. Rather, this is really the best practices that sometimes get forgotten because, frankly, they're just less cool. These are the things that often don't get presented in world-class presentations or in state-of-the-art papers. These are, I guess we can call the blue-collar but critical interventions we can do to deliver the highest level of neurocritical care. We're going to divide this discussion into two areas. The first, non-pharmacotherapy, and the second, pharmacotherapy. Let's start with the non-pharmacotherapy best practices. I can think of about 5 things that I do for these patients shortly after intubation. Number 1, keep the head of the bed elevated to 30 degrees. This has a few benefits. If they have elevated ICP, on average, this will decrease it by 5 millimeters of mercury. But it also reduces the risk of aspiration. So even during transport, I'll keep the head slightly elevated. If the spine precautions are still in place, reverse Trendelenburg is a pretty excellent compromise. Number 2, I'll relax the C-spine collar. While we're up at the head of the bed, I make a point to relax the collar by loosening it somewhat. I don't mean remove it, but I ensure it's not overly constrictive, as this will lead to sores and it also increases ICP. A nice touch, if you have it, is to switch patients over to a more comfortable Aspen collar, especially if you think they're going to be intubated and managed in C-spine precautions for some time. Despite being intubated, patients still experience pain, so I try and make sure any opportunity to reduce pain is undertaken whenever possible. This has the added benefit of reducing opiates, which we'll talk about shortly. Number 3, I'll place an AOG tube. This helps decompress the stomach and it may reduce discomfort. If there is elevated ICP, then any reductions in pain can have benefits there too. Number 4, I'll place a Foley catheter. Similar to the OG tube, this just makes sense to keep the patient as comfortable as possible. We regularly see patients in the ED and urinary retention, and they come in with incredibly high blood pressures. This is no different. We should employ all non-pharmacologic therapies when possible to maintain a suitable blood pressure. And finally, number 5, put in an art line. I'll tell you my bias is to put one in before we intubate, but if you haven't, make sure an art line goes in at least shortly after. We know that BP variability is a key modifier in outcome. High BP ability can worsen outcomes by 3 or 4 times more than those with stable BPs. With such a critical value, why shouldn't we look to have continuous BP monitoring? It will drastically impact how we sedate these patients, whether we're optimizing their analgesia, and it will give us a real-time sense of any clinical deterioration. Okay, now let's shift to a few pharmacotherapy best practices. What I'm going to mention follows the best available evidence, though isn't really necessarily specific to head-injured patients, but I will extrapolate and provide some rationale. I also acknowledge that this may be counter to what some people currently do in practice. Hopefully, with me providing some of my rationale, this may support a change in your practice. Number 1, propofol should be the standard infusion sedative for these patients, full stop, not benzodiazepines. In fact, I almost never use benzo infusions. I say almost because I don't like being absolutist in medicine. It's invariably wrong. But I really can't remember the last time I used a benzo infusion. When I have a trauma patient arrive on midazolam infusion, I immediately turn it off. The issue, and this applies broadly to all intubated patients, is that the medication accumulates and leads to oversedation. If you need a bolus of benzos, that's fine, but propofol is your go-to for sedation infusions. It allows your neurosurgical and ICU teams the opportunity to quickly turn off the infusion and reevaluate the patient's neurologic status. Number 2, have boluses of sedation ready immediately post-intubation. The streamlined approaches have the propofol infusion ready immediately post-intubation, but sometimes it's not possible or inadequate. So have a bolus drawn up in a syringe. I don't rely on the infusion pump boluses because they usually max out at 20 to 40 milligrams. Number 3, if you need to, use norepinephrine to support your BP targets if propofol causes some hypotension. Obviously, if it's profound, turn off the propofol and maybe try something like ketamine boluses and look to add a bit of volume. Certainly, if there's high ICP, then 3% saline boluses might be suitable. But mild hypotension or values just below your BP targets can easily be managed with a little bit of norepinephrine running in the background. Number 4, don't use opiate infusions. Use opiate boluses for analgesia. I used to give patients a propofol and fentanyl infusion, but now I use propofol infusions together with fentanyl or hydromorphone boluses. Early in the resus, I usually use fentanyl because it often provides a bit shorter duration in case there are hemodynamic consequences. But once I've gotten the CT and I have a sense of the patient's hemodynamics, I transition to boluses of hydromorphone. Opiate infusions might be fine for 1 to 2 hours, but I'd rather just start with boluses. The reasons are numerous. There's no high-quality study showing benefit, and in fact, there are real risks. Ones that we may not appreciate in the ED, but for our ICU colleagues, and certainly the patient, it's real. Opiate infusions can impair the extubation process by causing drug accumulation in adipose tissues and subsequent prolonged respiratory depression. Patients also have higher rates of delirium, and over time they develop opiate-related hyperalgesia, so their pain isn't even really being effectively treated. I haven't used a fentanyl infusion in a long time. I usually now give 25 to 50 microgram aliquots of fentanyl. I monitor their heart rate and their blood pressure. After I've gotten the CT, I'll transition to 1 to 2 milligrams of hydromorphone IV and ensure that the propofol is keeping them sedated. Okay, so here's the recap. For non-pharmacotherapy best practices in these intubated head-injured patients, keep their head elevated, loosen the C-spine collar, put in an OG and a Foley, and make sure they get an art line. When you're thinking about sedation and analgesia, propofol's your go-to. Avoid benzos. Use opiate boluses, not infusions, for analgesia and pain relief. And if you need to, add in a little bit of norepinephrine. That's it. My nuanced take on bringing your neurocritical care to the next level. Keep doing the amazing work you're doing. We'll talk soon.
And now a word from one of our sponsors, Quinty Health. Are you looking for a fresh start in emergency medicine or the right place to take the next step? At Trenton Memorial Hospital, they offer more than just a job. They offer a collegial team, excellent compensation, and real support. If you're an experienced EM physician looking for a well-run collaborative department, this is a rewarding, high-volume environment where your skills are valued. If you're early in your career or transitioning from family medicine, their hands-on mentorship program has your back. Work side by side with seasoned emergency physicians for 4 months with structured onboarding designed to build your confidence and clinical independence. Earn up to 600,000 Canadian annually with 75,000 in incentives plus relocation, licensing, and immigration support. Trenton Memorial Hospital is located near Toronto, Ottawa, New York State, and Vermont, and just minutes from beaches, wineries, and outdoor adventures. Visit quintyhealth.ca, that's QUINTE health.ca, and click Physician Opportunities to learn more.
Could this be a huge practice changer? Or is the data just too low quality? Honestly, this time, I just don't know, and I would love to hear opinions from listeners, so leave comments if you have them. The issue at hand, how fast should we be correcting sodium in severe hyponatremia? And if you're anything like me, your entire treatment strategy is based around one entity, osmotic demyelination syndrome, right? We were taught to go slow. We were taught that if we go too fast, we can cause some pretty awful neurologic consequences. So as an emergency doctor, I have mostly ignored hyponatremia. I mean, unless there are seizures or neurologic symptoms, the need for slowness sort of takes this out of emergency treatment. So I can just sort of ignore it, leave it for the internist, right? Well, it turns out that might be entirely wrong. Apparently, there's a lot of data that suggests correcting sodium too slowly can increase mortality. This came to my attention in the form of a systematic review and meta-analysis. This is AS 2024 in JAMA Internal Medicine. They looked at hospitalized adults with severe hyponatremia, defined as a sodium less than 120, or severe symptomatic hyponatremia, so a sodium less than 125, plus severe symptoms, which would be things like cardiorespiratory distress, seizures, or a GCS less than 8. So the group of patients we're considering is sick patients or patients with a really low sodium, which is good because that's exactly the group of patients where demyelination is a concern. Like, if the sodium is 127, who cares? Do whatever you want. They then divided the sodium correction rate up into 4 different categories. So it was very rapid, was more than 12 milliequivalents per liter in 24 hours. Rapid was 8 to 10. Slow was less than 8. And very slow was less than 4 to 6. And there are some ranges and some overlap there because different studies use different definitions. Their primary outcome of interest is mortality, although they all obviously also looked at osmotic demyelination syndrome. They found 16 studies, almost 12,000 patients, 14 retrospective studies, 1 prospective cohort, and there was an RCT, but it's not designed to answer this question, so really it's used as a prospective cohort. The mean sodium was 115 milliequivalents per liter. And here's the headline news. There was an association between faster sodium correction and lower in-hospital mortality. I'll say that again, lower mortality. And I like the way they present their data. They do give us the odds ratios, but they also try to estimate absolute risk. And that's really important here because the baseline risk for mortality is very different from the baseline risk of osmotic demyelination. For mortality, they think that there is a statistical dose-response relationship so that the slower you go, the higher your mortality. They estimate that going slow would cause an extra 32 deaths per 1,000, or a 3.2% absolute increase, and going very slow would cause an extra 221 deaths per 1,000, or a 22% absolute increase. Those are big numbers. Those are massive numbers. 3 and 22% absolute increases in mortality. Now, of course, this is observational data. We can't prove causation, and so we need to be very cautious here, and I'll come back to that. But let's briefly talk about osmotic demyelination. There were not statistical differences between the groups. So no difference in the thing that we're supposed to care about the most. Now, that's probably just because this is such a rare condition that they remain underpowered even with 12,000 patients. So this doesn't prove that there are no differences. But if mortality is common enough that you can see a difference and osmotic demyelination is so rare that you can't see a difference, the question is which should be driving your clinical decision making? For years, we have made decisions based around the very rare osmotic demyelination syndrome. But it seems like that might have been a mistake, maybe a huge mistake. In terms of absolute numbers, they saw osmotic demyelination in 0.3% of the very rapid correction group, 0.5% of the rapid group, 0.2% of the slow group, and less than 0.1% of the very slow group. So they were all less than 1%. Now, I could look at those numbers and think maybe there's a dose response curve there where increased speed of correction does increase the rate of demyelination, but I could also look at those numbers and just see absolute noise. In terms of absolute numbers, these authors estimate that going slow could result in 0.5 less cases of demyelination per 1,000, and going very slow could result in 2 cases per 1,000 fewer. But compare those numbers. Mortality increased by 32 and 221 per 1,000. Osmotic demyelination decreased by 0.5 and 2. The numbers are orders of magnitude apart. So it's very possible here that we have been causing dramatic harm, all because we've been scared of this demyelination boogeyman. And there are some other numbers in here. Hospital length of stay obviously goes up if you're treating people slowly. That makes sense. But none of the other numbers really matter if these mortality numbers are true. But of course, this data is far from perfect. There are many reasons why the mortality numbers might not be true, or might not be causal if you want to be more precise. The big concern here is confounding. Why are the patients severely hyponatremic? Or more importantly, why did the doctors decide to treat them at different rates? Or perhaps, why did their sodium correct faster despite getting the exact same therapy? We really just don't know. This paper doesn't have access to the underlying patient data that we would use to guide clinical decisions. It's very likely that clinicians acting with more information are treating these patients differently. They might opt to go slowly in patients with severe cardiac disease. And maybe it's the cardiac disease, not the hyponatremia, that's actually driving those mortality numbers. I've read a number of other sources about this, and it does look like the slower treatment groups do seem to have higher rates of cirrhosis, higher rates of heart failure, and higher rates of metastatic cancer. And therefore, we need to be very cautious in how we interpret this data and how we apply it clinically. There's a reasonable chance that confounding is making this data very, very messy, despite any attempts that we make to adjust the data. One thing is very clear. We need proper RCTs. Mortality is a very important outcome, and we just can't continue to practice based on this fear of a boogeyman. But the hard part of medicine is to know what we're supposed to do while we wait for that science. I mean, science is great, but I still have to look after my patients tomorrow. There are other studies out there that suggest that the link between the rate of correction and demyelination is actually pretty tenuous. It looks like there might be a much stronger correlation between the patient's baseline health and demyelination. So things like alcohol misuse and malnutrition, those are the things that really seem to drive this horrible outcome. But unfortunately, we can't control those variables. Clinically, I think the most important information that I could find is the rarity of osmotic demyelination, less than 1%, as compared to the overall mortality, which seems to be at least an order of magnitude higher. So as I said at the outset, I'm not 100% sure what to do with this data. And luckily, it probably doesn't matter that much for most emergency physicians, right? So severe symptomatic patients, and I've seen a number of these recently, they get hypertonic saline. That's easy. We need to get their seizures or their encephalopathy stopped. And the rare osmotic demyelination just isn't on the radar while these patients are still critically ill. For everybody else, the emergency management is still, relatively easy, right? We break these patients up into 3 broad categories based on fluid status. Are they euvolemic, hypervolemic, or hypovolemic? And the nice thing is that 2 of those categories have the exact same management, right? We do nothing. The treatment is fluid restriction, so we write an MPO order, and at that point, we can just let the admitting doctor sort it out. So the only thing we need to decide is this patient hypovolemic? If the patient is dry, we do exactly like we do with every other dry patient. We give them some IV fluids or maybe some oral fluids if you're really good at this. And because the rate of correction is over 24 hours, it really shouldn't be that big of a deal for us in the emergency department. But if you're going to be looking after these patients for any period of time, you'll want some repeat labs. And if you're getting close to that 10 millimole correction rate over 24 hours, right? The standard thing has always been give them some DDAVP, stop your IV fluids, and sort of reassess that rate for hypovolemia. But this patient really highlights that we don't need to be quite so scared, or maybe we don't need to be quite so scared about getting that sodium up. In fact, maybe it is exactly the opposite. With this strong correlation with mortality, there's reason to believe that this is going to shift to become more of an emergency medicine problem, that we're going to want to get these patients corrected faster. I would love to hear other people's opinions about this because I am sure that there are some smart nephrologists out there that understand that distal convoluted tubule and the collecting duct way better than I do. For now, I just raise this as very interesting data and maybe one less thing for me to stress out about on a shift.
Thanks so much, Dr. Morgenstern. Next up is the best of Don't Forget the Bubbles, the fantastic pediatric EM FOAMed outfit with Dr. Andrew Tagg. And he's going to talk about a little thing that I see just about every month where I work, and I've seen a huge practice variation in how it's managed. Here's Dr. Tagg on the management of Paronychia.
It's Andy Tagg from Don't Forget the Bubbles. And today we're diving into yet another common pediatric condition, Paronychia. So let me tell you about Noah, a 4-year-old who came in clutching his finger, refusing to let anyone near it. His mum thought it might be a splinter, but it turned out to be a classic acute paronychia. And a whole lot of distress over something that looks deceptively small. Paronychia, or inflammation of the skin around the fingernails or toenails, it's a frequent presentation in our emergency departments. And whether it's a toddler who's a little too enthusiastic about nail biting, or a teenager with an ingrowing nail, recognizing and managing it can prevent unnecessary pain and repeat visits. So today we're going to break down paronychia into 2 broad categories: acute and chronic. These differ not just in the timing, but in their underlying causes, symptoms, and treatment approaches. Let's start with acute paronychia. You've all seen it. Picture a red, swollen, tender finger, usually following some minor trauma, nail biting, finger sucking, or an overzealous manicure. Those all can create tiny breaks in the skin that become portals of entry for bacteria. The usual suspects, Staph aureus and Strep pyogenes. These are normal skin flora, but once they sneak past that barrier, they can cause a whole lot of inflammation. You'll often see redness and swelling at the side of the nail, around the paronychium, and in more advanced cases, a yellow-green fluctuant abscess may form. That pocket of pus may extend under the cuticle and, if ignored, could spread to nearby tissues, causing cellulitis. And rarely it can go deeper, causing osteomyelitis. If these infections recur, they can cause long-term nail changes like ridging or thickening. Systemic infection is rare, but something to keep in mind, especially in immunocompromised children. Now, here's something interesting. Despite their frequent use, topical antibiotics don't actually add much. They often can't penetrate inflamed tissue well enough to make a real difference. So what's the mainstay of treatment? Like any abscess, it's drain that pus. That's it. Simple. Physical release of the pressure is what actually helps. So here's my go-to method. Start with a warm water soak, and I usually just grab an empty urine pot, add warm tap water, and let the child soak the finger for about 10 minutes while I go and see someone else. Then, when I get back to them, the skin should be nice and soft. I take a green needle and use the beveled end like a spoon, gently sliding it under the lateral nail fold. Your goal is to lift the eponychium just enough to let the pus out. Once you've done that, most of the pain dissipates and the source of infection is dealt with. Actually, you can show the parents how to gently lift the nail fold a couple of times a day if needed. Some people leave a wick in place, but honestly, they tend to fall out, so I don't usually bother. If there's surrounding cellulitis or lymphangitis, then a short course of all antibiotics like Fluclox or Cefalexin is reasonable. And a word for the worried parents. Yeah, it can feel dramatic, but I always explain that we're not cutting anything. We're gently relieving the pressure and preventing a more serious infection. And that usually puts them at ease. Now, let's pivot to chronic paronychia. Unlike the acute form, chronic paronychia is about repeated exposure to moisture, irritants, or low-level trauma. Think frequent hand washing, thumb sucking, or kids with underlying skin conditions like eczema. This is a detective game, and your first step is to identify the trigger. Prevention is the key. Keep hands dry, use gloves for wet tasks, apply barrier creams, and manage any underlying dermatological conditions. Infections may still occur, but they're usually secondary. So remember to do cultures if you need to and treat accordingly with antifungals or antibiotics. But the real win here is education. Help families understand what's happening and why so that they can break the cycle. Chronic paronychia needs follow-up, so if you're not seeing an improvement, consider referral to dermatology. Now, before we finish, quick reminder of some conditions that mimic paronychia and require a very different management. First up, there's herpetic whitlow, caused by HSV. It presents as a painful blister. This one needs antivirals. Then there's the phelon, not the criminal kind, but a deep fingertip infection. This needs a different drainage technique. And finally, a rare one, acrodermatitis continua of Halepo, a pustular psoriasis affecting the nail bed. These are tough cases and should be managed with dermatology support. So what's your takeaway here? Paronychia may look small, but it matters. We've covered how acute cases can stem from bacterial infection after trauma, and that drainage, not antibiotics, is often the most important step. We talked about chronic paronychia and how prevention and skincare are key, and we flagged a few mimics that can lead us astray. Pain brings these kids in. Relief sends them home. And sometimes, all it takes is a bit of warm water, a green needle, and a calm explanation.
Thanks so much, Andy. We'll have images for you of the Paronychia mimics and how to drain them in the show notes. We have just one more sponsor announcement before we hear from EM living legend, Judy Tintinalli. Let's take a little break to hear from one of our sponsors, Metricade, the experts in complex physician scheduling since 2012. Metricade's expert schedulers are their secret sauce. These people truly understand the complexities of physician scheduling. They empower us by providing the tools we need to manage our teams efficiently. At the same time, they give physicians more freedom to share their workflow preferences, so schedules aren't just fair, they're actually workable. Metricate's system is built to make your schedule work for you. They take the stress out of shift planning so that you can focus on what matters most. Go to metricade.com/emcases to learn more about how smarter scheduling can work for you. That's metricaid, one word, .com/EMCASES.
Hello, everyone. This is Dr. Victoria Myers. I'm an emergency physician in Toronto, Ontario at St. Michael's Hospital, and I have the pleasure of being involved in a leadership in emergency medicine series as part of EM Cases. And it is a true pleasure today to introduce Dr. Judy Tintinalli, who is here to talk to me about her journey as a physician leader. You may all recognize her name as she is a world-renowned educator, and you will definitely know her as she is the chief editor of Tintinalli's Emergency Medicine, the leading emergency medicine textbook in the world. She's also a professor and the founding chair of the Department of Emergency Medicine at the University of North Carolina at Chapel Hill. And I cannot count her numerous leadership positions as well as the innumerable awards that she has amassed throughout her career. She's truly one of the groundbreakers in our field, so it is a true honor to be here with her today. Thank you so much for being here with us, Dr. Tintinalli.
Well, thank you. This will be a fun recording.
I think so. So I think to start, I'd love to just hear a little bit about your journey as an emergency physician leader, how it sort of started and how it evolved throughout your career.
It seems to have just started. When you talk about my leadership career, I've actually started 3 different emergency medicine residencies. So I guess that's how it started. In 3 different environments, one in the City County Hospital, in Detroit at Detroit General Hospital, another one at a private hospital, which at that time was the largest in the state of Michigan. That was at Beaumont Hospital. And then I went to an academic center, University of North Carolina. So it was interesting for me to see the difference in patient populations, the kind of different ways things were done. And of course, I have 3 groups of residents that have graduated from these programs that are basically all over the country. And that is really, I believe, how I started. At any rate, I was a medical student at Wayne State. And of course, we did our rotations at Detroit General. And I was a junior and rotating through the ER. And a patient came in with lacerated Achilles tendon. And the senior surgical resident was Ronald Crome. And he said, "Hey, student, come here, sew this up." I'm like, "What? How do I do this?" And I did what he said, put a cast on, and I'm like, this is really cool. And that's how I started my love for emergency medicine. So I did a straight medical internship, but was able to add on all kinds of different rotations. I did ENT, anesthesia. And then after that, I worked in the ER at receiving as an ER physician for 2 years. By then, I had 2 children. And this is how ERs were run at that time period. You know, whoever wanted to work there, you could work there because there was no staff. Then it was time for residency. Well, I had 2 children, was married at that time, and could not move. So I applied for whatever residencies I could, and I tried at Ann Arbor. I was then pregnant with my 3rd child and I couldn't believe it. I went for an interview, told them I wanted to do emergency medicine, and then time came to make a choice. And the other programs I had applied to in the area said, "Of course, you're in, but let us know by this date." And I hadn't heard anything from Ann Arbor. So what I did was, in my naivete, I picked up the telephone and I called the chairman of internal medicine. His name was William Robinson.
Wow.
He was a rheumatologist. He answered the phone.
I don't think that would happen today.
him that I was dying to go to Ann Arbor. And he said, just a minute, let me pull up your record. And I waited. And then he said, okay, you're in. Come on with us. And I point that out because it is so unusual. I still can't believe it, but it is a point I want to communicate to others. Don't be afraid of trying. I remember I wasn't afraid when I called him. Now, today I might be because a department chairman might not want to talk to me. But then in my naivete, I was not. And a lot of the things that have happened throughout my life had to do with that. We'll just try to give it a chance.
There's a real beauty in that lack of fear from just not having a full picture of maybe who somebody is, or that you should be afraid, which we all probably shouldn't, to go out and ask for what we want and try things. But I think there's a beauty in sort of the ability to just pick up the phone and call because you are sort of focused on your own goals and don't have a full sense of maybe who you're calling or what you're asking for. And that's probably why you got in, I bet.
I think it certainly helped in the way I progressed. Another crazy thing is when I was at Detroit Receiving Hospital, I was writing for JSIP and doing case conferences. So I got a lot of experience in writing. And there was an ad in JSIP asking for a person who would be interested in writing the first textbook in emergency medicine. It was an ad from ACEP. And I answered the ad. I was the only one who applied. And that is how everything started with the textbook.
Wow.
As the first 2 editions were published by the American College of Emergency Physicians. And then it was after that that we were picked up by McGraw-Hill.
Right. So that started all from an ad that you answered.
I kid you not. That is how that started.
The birthplace of Tintinalli's emergency medicine. And how did you put together the first edition? What was your approach to it?
At that time, there was a Scientific American journal that came out like a loose-leaf notebook. And I had been reading that and liked it. So the first edition was 2 loose-leaf notebooks. Now, there weren't many people available to write. I actually probably wrote 90% of that first book, but I had pediatricians write peds and some other on the mental health. I had some colleagues, but that was how the first one began. And the reason they were looking for a person is because with a series of the early emergency physicians, and Peter Rosen was one of them, they had to look through and decide what content was important for emergency medicine. So they went through all the standard textbooks, Harrison, Schwartz, surgery, all the pediatric books, went through it and wrote down a list of questions and then a list of answers. And these were filed as individual pieces of paper per question. They were all in a room filled with papers. And that is how I didn't use their questions or answers, but that is how the topics were developed through all this room filled with papers.
It's really sort of the origin story of our specialty in terms of we answer the few questions of every specialty in the first 15 minutes that the patient is in the hospital. So it's so funny that you pulled from sort of all of those texts to then decide what we needed to know in emergency medicine, but it makes total sense. So what I'm hearing so far is it sounds like your career sort of began based on really your own interest and willingness to put yourself out there and go after what the things that you were interested in and wanted to do. And that led to a lot of opportunities that have sort of blossomed into your career as it went.
It did. Just to take that step forward.
That first step. Let's talk a little bit about professional development. What has your approach been to that throughout your career, and what specific advice do you have for our listeners about that?
Well, I wrote some notes and I separated it into professional development practice and professional career practice. And in the development practice, There are many traits that in my observation and in my own practice of those who were successful as well as unsuccessful, things that I have seen and also tried to emulate. I was very lucky in that early in emergency medicine, I was able to observe all the big guys and see how they ran meetings. I had to learn Robert's Rules of Order. I'm like, what is this that they're following? And I could watch those who were successful, those who were very abrasive and aggressive. And I think that the early leaders were quite aggressive and sometimes abrasive. And I must say, I picked that up early on. And because I was modeling myself after the big guys. And later on, especially when I got to the University of North Carolina, some of my good mentors there said, just take it easy. Things will move along. They're not going to happen overnight. I never really quite learned that. So what I have learned is, as a leader, you have to support others. Whatever it is their problems are, whatever mistakes they've done, whatever good things they've done, they need support. And that's very important for a leader. Another key element is set a good example in every way you can, in clinical work, in relationships, in making sure you know how to give compliments when they're necessary, learning how to help people learn from their mistakes, being on time for meetings, being prepared for meetings. All of those pieces, you have to set a good example. Then you have to learn how to be a time manager. You sure need to manage your time because you'll have a lot of things to do. And you can then, by setting an example or helping others manage their time. Another feature of leadership is you have to send out continual messages, overt and not so overt, that we are all part of a team and working together. And everybody is important no matter what their role is in that team. Big, important feature of leadership is you have to listen. Too many leaders love to hear themselves talk. So they'll set up meetings and you listen to the committee leader talking. That is not the point. The point of these meetings and where you are a leader is to listen to what others say. And a big deficit I've seen throughout my whole career, oh my goodness. Why not ask others for their opinion? And I think that improves the whole institution. That seems to be a fault of all administrators, especially with the hospital setting. They don't want to really give time to hear everyone's opinion. You listen more than anything when you lead.
I think sometimes too, when we're making big decisions, the loudest voices in the room can get heard the most, especially when the person leading maybe doesn't have the ability to pull out opinions and ideas from the people who maybe are not natural to speak up the loudest, give their opinion. And some of the most, I think, golden nuggets of ideas come from people that maybe speak up less often, but are thinking a lot.
So as a leader, then, you have to learn how to interrupt these other people who keep leading without being grossly offensive. They think, shut up, we've heard this 10 times. Those are very good ideas. Let's open it up to the group and hear what others have to say. And you can pre-package these kinds of phrases and even write little notes for yourself. And people think you're looking at the agenda when you're looking at the phrases that you really want to say. So those are all little tricks. And then at the very end, as a leader, you need to get things done. And for example, every year you have a meeting with residents and they list all the things they like, but mostly what they don't like. And at least what I used to do was keep an agenda, keep them informed of the things I could change, could not change. And then next year we would go over that again. So that was a simple way of tracking what you were doing and what you could accomplish. And depending on who you're working with, That's an important way to, I think, end these ideas about professional development practice, is to make sure you get something done. A lot of people, though, you never hear what they've done, or maybe they've done nothing, but it's important to communicate that to your team.
Okay, great. I'm just going to summarize the discussion so far just for our listeners. So I think I heard some really key things that you've seen help leaders succeed throughout your career. The first one is being supportive of all of the people that you're leading, that always being there for them no matter kind of what they're going through, whether it be professional and personal. A huge one that I think is undervalued is setting an example with your timeliness, with your preparation, with the kind of staff that you want your own staff to be. You kind of show that in your everyday work. You also manage your time, and in managing your time, you can help other people manage their time. And then I think listening, which is probably the most important point that you said, that kind of listening to everyone else rather than speaking yourself helps gather good ideas. And I love the pearl of looking at your notes, pretending it's the agenda with some like pre-stocked phrases you have to help kind of direct the meeting the way you want. I think I'm going to take that one. Okay. Let's talk a little bit about practice expansion and how you approached that throughout your career. You are double board certified in emergency medicine and internal medicine. Is that right?
Yes.
Nice. And how did you approach sort of your practice expansion in your career?
There was an article that was just written by Michelle Lynn and Rochelle Cooper. Is emergency medicine a career or a pit stop? And that's in the Annals of Emergency Medicine. And what a great title. And that is one thing that residents and faculty need to think about. It's really a lot of fun doing ER when you're starting. You can work 5 shifts in a row. You can do 12-hour shifts. But you really can't keep doing that when you're 50 or 60 years old. And it is interesting because the original ER docs kept working clinically. After I left chairmanship, I went back to clinical work, not full time, but I think I was doing 6 shifts a month, and I worked only 3 to 11 and 6 to 2. So my life is now on a permanent afternoon shift. I retired clinically in 2021, but not academically. So because you have to think about emergency medicine as a career, you should start after the first couple years of practice, really thinking about how are things going to really move forward. And this is a good idea for anyone, no matter what your profession, your career, your job is, whether you're a homemaker woman, what's going to happen to you when your kids all grow up and you don't have the enjoyment of being with them at home all the time. So I like to think in terms of 5-year goals and sort of plan ahead. What are things going to look like in 5 years from now? And I felt that way as I moved to each emergency department where I started a residency. When I was at the city county hospital, city county, we all know what that is. And I finally thought, I don't know if I can keep doing this environment for a long time. So I went to a community hospital where I did a second residency. That was so interesting. My first shift, I saw somebody come in a cervical collar. I'm like, what's that? Well, at the city county hospital, right in downtown Detroit, you had gunshots. We had no EMS system. And there were no such things used as cervical collars at that time. So you then learn about different ways of practice. There was a lot of difficulty in relationships at the city county hospital with surgery, except for Ron Crone, who sort of crossed all the barriers. But suddenly I got to the community hospital, and I'm like, holy smoke. When I say community, they had residencies in all areas. They had the greatest number of OB cases of any hospital in the state. Oh my God, radiologists and surgeons were your friends. Plus, you saw way different diseases and different ideas of treatment. So this was a goal. Then I did that and I'm like, there's clearly no way to move up in this setting because there were a lot of individuals who grew up in that hospital setting in administration. Emergency medicine was still new. I'm like, well, I guess I would be doing this for the rest of my life, residency director, then be the head of the department, which was yet it was not connected to a medical school. So I applied again, just applied to the University of North Carolina. I saw an ad somewhere. I wasn't called by a headhunter. And so I wasn't nervous when I went for the interviews because I thought, there's no way. And I got them that job and was able to put together in managing the department and setting up the residency, the things I had learned from 2 other environments of practice. So planning, you need to think ahead and say, am I really going to want to do this? And that's why you think about a career or a pit stop. It can be a pit stop to the whole career, and you can move differently if you prefer. I think advanced training is very important, and I recommend that to all residents. They already had big loans when they graduated. Okay, start paying off your loans, but think about what else you want to do. And many now are doing fellowships because they're already doing that planning earlier on. I got my MPH late. I wish I had done that earlier, but this was because, and Ann Arbor still has an excellent school of public health. And so I did that later. I think my whole career might have changed a bit more to be doing more database research than I have done. But I'm pretty happy. I just thought, well, if I had known about it earlier, I might have done it earlier. I always recommend to faculty to stay clinically active for a very practical reason. This is how you make your money. So it's very important, should things change on your administrative path or anything happen, if you remain at least minimally clinically active, you can expand your opportunities as opposed to stopping practicing emergency medicine entirely. Staying clinically active helps you keep up with what's going on. So it's not only, it also makes you a better administrator, a better team worker, because you will see what the real problems are and experiences are as well. In terms of expanding practice, I also think it's good to work with individuals outside of emergency medicine. So a lot of young faculty now get an MBA. I did a 2-week pre-MBA course when I went to the University of North Carolina. And I'm like, okay, the big thing is I have to hire an administrator who knows how these budgets work. But however, you learn to talk the way other people talk. People hate doctor talk if they are non-doctors. So you learn to communicate in other languages. And that's even true in public health, where you will meet individuals of many, many different backgrounds who are working in public health, as well as sociology. So you can then learn to expand your practice. I've done telemedicine a little bit because when Suboxone came out, I got one of the early exemptions. I took the tests and the classes and all that and worked with the Department of Psychiatry as they were setting up a outpatient Suboxone program. And, woo, boy, I really like telemedicine. And so there are different ways of expanding your practice: ultrasound, telemedicine, public health, that can help you decide how you're going to move on in your career.
I think they sound great. I'm just going to summarize them for our listeners. So it sounds like planning out your goals and your kind of next 5 years allowed you to really get the most out of portions of your career and to experience different practice settings, which really expanded your clinical experience and knowledge. And you were able to carry skills from hospital to hospital that sort of helped you grow and the hospital grow with you. And I also hear again this theme of just going after opportunities, applying for things that you're not sure that you'll get in your journey to UNC. And then the other key pearls that I heard there was that expanding cross-professionally is really important for our communication style and for sort of learning from other professions and other specialties and our ability to sort of communicate and bring things back to medicine that is not just doctor speak, so to say.
I'd like to add one more thing about expanding your practice. And I do talk about this experience in some of my lectures and Zooms that I give. I was at the University of North Carolina, and I had another appointment in public health and administration and all of that. And then I heard that they had a director of medical journalism in the School of Journalism and Mass Communications. I'm like, I got to talk to these guys. And so I talked to those guys. I went there, and the head of medical journalism became a good professional colleague. We developed a rotation in the ED in the medical journalism program. This was amazing. It went on for about 12 years. We couldn't do it today because everybody's scared of lawsuits and HIPAA and whatever. And it had to end at COVID because nobody could then come into the ED. But these were undergraduates. These were graduate students. They had a variety of backgrounds. I believe that getting involved with the news media is critical for emergency medicine because nobody understands, even to this day, what emergency medicine is. So these individuals would come in, they would move around on a certain number of shifts with a specific attending, and they were allowed to interview a patient, interview nobody, interview the doctors, and write an article for a local paper. Wow. Every week, there would be an article in the paper, and I think it really helped the different kinds of communication papers that were available. Even the big state paper had articles. And through this, the newspapers themselves knew who to contact when there was news about emergency care.
Wow, that sounds like an amazing program. So you kind of mapped out your career in 5-year goal sections. You're a big proponent of advanced training, which I think is becoming more common these days. And it allows you to sort of expand your practice beyond just your clinical work. Staying clinically active is really important for both your ability to go back to increased clinical work should you need and to keep you updated about what's going on in the specialty. And cross-professional relationships, especially those that help you with communication, like journalism, really kind of enhance your ability to expand your practice and provide new opportunities. You know, you're not the first person in this series I've talked to that has advanced training in journalism or an advanced sort of connection to journalism and communication, interestingly. I think it's a common thread amongst physician leaders that we have developed extra skills in communication, which probably is a key point there that maybe is understated. Is there anything else you want to chat about or talk about or advice you want to give before we close?
The only other points that I see mentioned a lot are mentorship and sponsorship. And what I find interesting is we know the difference. Sponsorship sort of opens doors. And I've had a lot of individuals that helped open doors for me. And that includes people who elect you to different things. That opens doors. Mentorship is, people talk about like big things with mentorship. Somebody I can meet with every week and they'll tell me how to do this or that. A lot of important things are done that are very tiny, tiny things. And I'll give you one example. I was a member, I was elected to the American Board of Emergency Medicine. And I was just starting to go to the meetings. Now there, I was very scared, for sure. And so I would just sit quietly. I would read the agenda and was afraid to ask questions. I'm like, I'm the only stupid one here about all this stuff. And Jim Mills, there's an ASAP continuing award in the name of Jim Mills. He took me aside. He's like, Judy, you need to talk. You will never get anywhere. Ask a question. Don't be afraid of asking an obvious question, because I'll bet you none of us will know the answer. That was one small conversation which changed a whole lot of things. I would get little emails, not emails, that people would have to write letters at that early on. And people that I almost didn't know would say, congratulations on this, congratulations on that, or whatever. And I took that up as a way that is important for people to get complimented by you. So I really try to make it a practice. When I see a particularly good article like in JAMA or the JAMA Network, and I see the author as an emergency physician, I will send them a note and say, this was really a great article, and I'm glad you wrote it. Or little things, when you're working, you try to compliment people. These little things stick with you for a long time. And when things are tough, you can remember these little positive things.
Yeah, that mentorship is not these big conversations necessarily, but these tiny tips, tiny compliments, the small stuff sprinkled into our everyday life is really probably what helps us grow the most.
Yeah.
Super inspiring. Thanks so much, Dr. Myers and Dr. Tintinalli. If you've been enjoying listening to EM Cases or using the EM Cases website, packed with its show notes, quiz vaults, videos, and much more, please consider a donation. Just go to emcases.com and hit the red donation button. Hope you learned a little something from this EM Quick Hits. We'll speak to you again soon.